Hi there, I'm the neuromuscular mechanic, and today we're going to be talking about diagnostic nerve blocks of the ulnar nerve, and this is in the context of spasticity management. So when we look at nerve blocks, we always have to think about muscle innervation. So if we target a certain nerve, what muscles are we trying to reduce tone to? So in the case of the ulnar nerve, above the wrist, it provides motor innervation to the flexor carpi ulnaris, a wrist flexor, and the flexor digitorum profundus to digits 4 and 5. It innervates the hand intrinsics. Some relevant muscles would include the interosseae and the lumbricals 3 and 4, which contribute to that intrinsic plus deformity, as well as the adductor pollicis and the flexor pollicis brevis with a thumb and palm deformity. When we do nerve blocks, the reason we do them is to temporarily reduce tone to spastic muscles, and that allows us to gauge the functional impact of reducing tone to determine whether or not it's warranted to sort of pursue more permanent treatments such as neurectomy. So in the case of the ulnar nerve, we can target it with the goal of potentially reducing wrist flexor tone by reducing tone to the FCU, addressing finger flexor tone, or thumb and palm deformity. Clinically, where I probably do this nerve block the most is distally at the distal forearm to sort of simulate the effects of a distal ulnar neurectomy, which can be used for things such as a thumb and palm deformity. So that's sort of how I approach the diagnostic nerve blocks. When it comes to your ultrasound technique, one place that you can start is at the retroepicondylar groove or the ulnar groove. There's really only one structure that runs through here. It's the ulnar nerve. And so if you put the probe in short axis, sort of spanning the olecranon and the medial epicondyle to identify the nerve, then you can scan distally in the forearm. And remembering that sort of mid-forearm, the ulnar nerve will meet up with the ulnar artery, or you could scan more proximally from the elbow if you're doing a more proximal block. So we're going to start with the ultrasound. I'm going to pause here. So here I am at that retroepicondylar groove, and you can appreciate the ulnar nerve, which I've labeled, which is sort of relatively anechoic in this area because of anisotropy, and it often appears this way is easy to distinguish. And then I'm going to move the probe now more distally. The ulnar nerve goes through the two heads of the flexor carpi ulnaris, which you can appreciate here. And then in a moment, I'm going to scan more distally, and you're going to see that ulnar nerve is going to start to course underneath the bulk of the FCU muscles. So if we pause there, there's the FCU with that prominent central tendon, and then underlying it, which I've labeled as UN, the ulnar nerve. And then what we will do in a second is we're going to sort of scan more distally. And so I'm just going to now in a second move to a new ultrasound video here. So again, there's that ulnar nerve, the nice sort of honeycomb appearance. And I'm going to start moving the probe distally. And what is important here is you're going to see that ulnar nerve join up near the ulnar artery, which I've labeled as UA here. And this is really important because when we do these nerve blocks, we're doing them in people who have spasticity. Often these surrounding muscles are hypoechogenic, so it can be hard to appreciate the nerve structure. And that's where knowing the relationship with the blood vessels is useful. It'll be right beside it. And I go sort of more distally here. Again, there's that nice relationship with the blood vessel. And so if I was going to do a nerve block here in the distal forearm, I could bring the needle in, sort of simulating that path here in red from sort of the ulnar aspect to radially, bringing that needle near the nerve, near the blood vessel, and stimulating. So next we're going to look at how do you target the nerve above the elbow. So keep in mind what I talked about earlier in the presentation, that you can start at that ulnar groove and then move the probe more proximally. And that's what we're going to do. So here I am at the ulnar groove, and I'm moving the probe more proximally in short axis. And there you can see the ulnar nerve that's running superficially that I've identified as UN. And so I could potentially target the nerve at this level if I wanted to potentially see what the impacts were of reducing tone to the FCU or the fourth or fifth fascicles to the FDP in addition to the hand intrinsics. So that's how this could be approached. And here I am following it a little bit more proximally. So I'm the neuromuscular mechanic, and I hope you found today's videos handy. Thank you.